Afternoon, everybody, and I'd like to echo Susan's welcome and thanks all for coming. And it's great to see so much interest in viral hepatitis in primary care. Just for my own information, can I get a show of hands? Who here is, I know we've got some secondary care nurses here. Who is the secondary care nurses? So we've got a few, good, not too many. And so that would probably, and maybe a show of hands, who else is prison, work in the prison environment? That's lovely, and so then that would assume that the rest of you then are all primary care, so that's great. Excellent. So what I'd like to talk about now is hepatitis B, really the management of it. What Dr. Moyes covered with you in the first two talks, there is a reasonable amount of overlap, a bit, and I think that that's actually a good thing. Hepatitis B is relatively complex. And I know that in the medical training, we heard a little bit about it as medical students, we heard a little bit more about it as junior doctors, and then when I was training for my physician's exams, I got my head around it a bit more, but it wasn't really until I became an advanced trainee gastroenterologist that I actually finally properly understood hepatitis B blood tests. So it is complex. So if all these antigens and antibodies blur into a big mess, you are not alone. Most doctors don't understand hepatitis B either. So the fact that some of my stuff repeats a little bit of what Dr. Moyes was saying, I think is probably actually a good thing. So we will make a start. So the things that I'd hope that you'd gain from this talk today is really to get an understanding of the hepatitis B blood tests and how we use those to then assess the person's hepatitis B and then allow that to guide management. We need to take into account a number of different factors of what's happening for the patient or for the client regarding the hepatitis B and their body. So hepatitis B in New Zealand, similar, well this is the same data that Dr. Moyes presented. We estimate the prevalence to be approximately 100 to 120,000 people in New Zealand are currently affected by this virus. The ethnic prevalences are outlined there, and Dr. Moyes showed them broken down into the more Pacific Island subgroups, and we know that Tongans have quite high prevalence. So when we are thinking about managing an individual person's hepatitis B, broadly speaking, there's three things that we need to take into account. We need to assess patient factors, virus factors, and liver factors. So this is where it gets complex, and so this is the bit that's a little bit repetitive. The virus is, we need to sort of really go back down into the medical sciences here. So hepatitis B is a virus that affects human liver cells. Serology is the broad group of blood tests that assesses what the human immune system is doing with a foreign thing coming into it. So when we're talking about serology blood tests, that's where we're talking about the antigen, the antibodies. All of those tests are serology blood tests. So when a foreign protein is in our body, from the perspective of the immunology medicine, we talk about that foreign thing as an antigen. So the virus is made up of a surface, an envelope, and a core protein, as Dr. Moyes showed before. And so those are the hepatitis B surface antigen and the hepatitis B envelope antigen, otherwise known as the E antigen. We don't usually use the whole word envelope, we just say E antigen. So that's where that word antigen comes from. So if you see antigen, or AG for short, it means we're talking about the virus. And this is a schematic similar to what Dr. Moyes showed. So we've got the outer surface component of the virus, the surface antigen, which not only encapsulates the virus, but is also floating free in the bloodstream, and that's what we're detecting. And then the inner components of the virus are ones that are only ever present in a person who's currently got the virus or has had it in the past. You don't get these bits from vaccination, whereas this is the bit that you get from you get exposed to when you have a vaccination. So thinking about it from the immune system perspective, when the immune system is exposed to a foreign protein, we develop antibodies against it. So the antibodies are specific to the thing that they're fighting. So it would follow then that if there is a surface antigen on the virus, then our immune system is going to create a surface antibody. So those two things, you sort of think about them together. Likewise, there is an E antibody and a core antibody. And there's the various different shorthands and the way that that can be written. So Hep B surface antibody or anti-HBs, they mean the same thing, just different ways of writing it. Does that make sense? Yes. Antigens and antibodies. Step one, done. Okay, so now let's go on from there. So then how do we interpret all these antigens and antibodies? So the surface antigen, if it is positive, if that is present in a person's blood, it means they have hepatitis B now. They are infected. And you can, either carrier, chronic carrier, infected, whatever, they have the virus. So surface antigen positive, that's the first thing you look at. If that's positive or negative, that tells you that the person has the virus. If the surface antigen is negative, that person does not have Hep B. And then you can look at other things to see whether they're immune or whether they've had it before or what have you. So the surface antigen is always the first thing you look at. If a person has hepatitis B, they are surface antigen positive, we would then do a second test to look for the E antigen and determine its status, positive or negative. We would only ever do that test on someone who we know has Hep B. It's not in the initial panel of bloods. In terms of the E antigen, being positive generally occurs in the earlier years after you've become affected, so it's usually childhood, because most people acquire hepatitis B in infancy and childhood, as we've just heard from Dr. Moyes. So most young people are E antigen positive. At some point in the teenage to early 20s, most people's immune systems manage to change the virus into E antigen negative status, and that is a less active form of the virus. And so most adults are E antigen negative. Most, but not all. So then thinking about the antibodies then, interpreting the antibody blood tests, you have to do that in the context of whether the person has the virus or not, because they mean different things. So first of all, the surface antibody. If the person does not have the virus, so their surface antigen is negative, and yet their surface antibody is positive, it means they don't have the virus and they are immune. Does that make sense? Antigen negative, they don't have it, but they've got an antibody against it. So they are immune. So they've either got that antibody because they've had the virus in the past and they've cleared it and they're now protected, or they have that surface antibody because they've been vaccinated. So surface antibody positive, when they don't have the antigen, means they are immune. The antibody can also be on a blood test result printed as a numerical value, and this is what Dr. Moyes touched on before. People can have a surface antibody that comes at a low titer, and the automated response on the bottom of the blood test report says this level does not suggest immunity. Now that's the bit that we disagree with, because we know that even if you got vaccinated as a 3-year-old, you do that antibody blood test as a 20-year-old, the antibody titer may be very low. Oh my gosh, I'm not protected. But as Dr. Moyes said, what we know is that if you were exposed to it again, your body would mount a response to that. And so if you have a normal immune system and you know you've been vaccinated, I'm not worried whether the antibody titer is low, because I know your immune system will bounce back if you become exposed to it. The only issue there would be if you are immunocompromised or immunosuppressed, that you may not be able to mount that adequate response. In terms of the core antibody, the vaccine only contains surface antigen. So if someone has a core antibody in their blood, it means that they've been exposed to the actual virus at some point. So it's a good indicator of actual past infection as opposed to just prior vaccination. Right. So some common scenarios, sorry, this probably isn't particularly easy on the eye, lots of antigens and antibodies, but we'll just work through it. So the top one there, surface antigen positive, surface antibody positive, core positive, and E antigen positive. Starting with the surface antigen, they have the virus, this person has hepatitis B, and because they are E antigen positive, we would say that they're in a highly active state of the virus. The fact that the antibodies are also positive doesn't change anything. It just means their immune system's been exposed to the virus and is trying to mount an antibody response. But because the surface antigen's present, that's the overriding feature. They have hepatitis B. The second one down, surface antigen negative, surface antibody positive, core antibody negative. The person does not have the virus. They are immune because they have surface antibody. And that's from prior vaccination because their core antibody is negative. The one at the bottom, surface antigen negative, surface antibody positive, core antibody positive. They don't have the virus. They are immune, and they're probably immune because of past infection, because that core is positive as well. Okay. Don't worry if that doesn't stick in your head. Like I say, most doctors don't understand all of that. So it's just good to hear it again, but don't panic if you can't memorise that. So coming now to assessing your client or patient in front of you, trying to determine what the next step or what the management needs to be. So the virus factors, we've talked about some of this. So the E antigen, are they in the positive state or the negative state? Are they in the really highly active virus state or the less active state? And then we need to do a viral load. The virus count per mil on the reports can either be reported as a logarithm value, which might be anything from 1, 2, 3 up to 8, and that's a logarithm value, or it will be a numerical value where it will say 800 or 2,000 or 10,000 or 8 million. We don't define different cutoffs at different levels of the viral load. But we do sort of in our own minds have a sort of a breakdown as to say, well, that's really low or that's really high. And we do sort of make clinical decisions depending on where the virus is. So a low viral count is anything under 2,000. And really, once your virus count is sitting above 20,000, we know over the long term that people persistently with a virus above 20,000 are more likely to run into problems. And then above that, they're even more likely to run into problems if they're in the sort of hundreds of thousands or millions. So that's not a strict textbook breakdown, but as experts, we look at that and we do want to get a sense of where that virus level is running. Co-infections with other liver viruses, such as hepatitis C or hepatitis delta or HIV, which is obviously not specifically a liver virus, do have an impact on people's outcomes, and we do need to know that as well when we're managing them. So looking at the whole person then, things that we need to take into account when considering their management. How long have they had it? And usually the duration of age is going to be answered by how old are they, roughly speaking. Their gender, males always do worse when it comes to any kind of risk factors for liver disease. Family history of hepatitis B, specifically if anyone in their family has had hepatitis B related hepatocellular carcinoma, which is the cancer that's very specific to the liver. That's a very important thing to know. And then other things outside of, viral matters is, well, what's happening in the rest of their lifestyle? What are their other risk factors for progressive liver disease? So alcohol use, none, mild, moderate. Do they have obesity or fatty liver disease? And as I've said, co-infection with other bloodborne viruses. And then there's other situations where the management of hepatitis B is impacted by the carriage of other medical conditions, such as if that person needs chemotherapy, if they're immunosuppressed, if they need to be on long-term prednisone because of arthritis. All sorts of other factors like that will have an impact on the treatment decisions for hepatitis B. And then thinking about more specifically in the liver, getting down into the sort of physiology of it all, we are looking for, is there any evidence of active inflammation going on in the liver? And that is best reflected by the level of the liver enzymes, the ALT and the AST. We also, in rather than a one-off, it's very much trend over time. So it's not really what's happening on one blood test, it's what's happening over time. We then need to know what's happening in terms of, the person's had hepatitis B maybe for 40 years, how much damage is present. We may only have blood tests from the last 3 years, but we've got a 40-year-old who's just been diagnosed, and it's like, well, hang on a second, we don't know what was happening in your liver for the preceding 35 years. So you could have very quiet blood tests now, but you might actually have damage already occurred in your liver. So this is where we need to be thinking about the stage of the liver disease. And by that I mean, is there any fibrosis present? And so we are looking, so fibrosis is the word we use for any scar tissue present in the liver. And if there's lots of scarring and it meets specific criteria, then we'd say the person has cirrhosis of the liver, which is when there is marked scarring to the point that it's architecturally and physiologically affecting the liver function. So cirrhosis is really end-stage scarring. So there are particular examination findings that we would look for that is present in people who have cirrhosis, but that only captures the very end of that continuum, whereas other tests such as fibroscans and other blood tests can help us try and work out whether someone is starting to move along that pathway of increasing scarring or fibrosis in the liver, even if they haven't got to full-blown cirrhosis. So we need to make an assessment of that. In terms of the liver blood tests, so the LFTs as a panel that you would see for your patient's blood results includes ALT, AST, GGT, ALP, bilirubin and albumin. The ALT and AST are the ones most specific and most reflective of active viral activity in the liver. So if a person has very active hepatitis B, it would be these two that we would see elevated. The typical reference range in most laboratories is less than 40, although that can be debated. And we would sort of talk about if someone's got persistent mild elevation and the ALT sitting somewhere between 40 and 80, then we would say, look, they've got mild elevation 1 to 2 times the upper limit of normal. It's a bit more moderate if we're seeing numbers running from sort of 80 to 200. There's definitely ongoing inflammation present there. And if someone's got an ALT of 500 or 800 or 1,000, then we would say, well, this is a significant flare, and this person really is running into danger, and we would want to check the other parameters of their liver. Is it still doing its job okay? Are they going into liver failure? The liver is an amazing organ. People can run along with ALTs in the hundreds and not go anywhere near liver failure. So someone might phone me and go, oh my gosh, I'm really worried. Someone's liver blood tests have come back and the ALT's 200, panic, panic, panic. And I guess when you're a specialist in a field, you get very comfortable with things. So I can appreciate that an ALT for someone who's not used to looking at LFTs might be really frightening. But for me, it's like, yeah, there's nothing, don't worry about it kind of thing. So the liver you can still have a normal functioning liver with ALT in the hundreds. It's just a reflection that there's a lot of inflammation present. To really see whether the liver is actually starting to run into some harm from that active inflammation, you need to look at the bilirubin and the albumin and also the INR, because they tell you how the liver is doing as a physiological factory. If the liver is actually starting to not be able to do its job very well and it's starting to fail, your bilirubin will rise, your albumin will fall, and because the liver makes clotting factors, your INR, which is one of your blood clotting parameters, will start to rise. If you're in that kind of territory, you need to be speaking to specialists in secondary care. Right. So why do we need to treat people with hepatitis B? Over years, persistent active hepatitis or inflammation in the liver can lead to progressive fibrosis, scarring, liver cirrhosis, liver failure, and also specifically liver cancer. As Dr. Moyes talked about, hepatitis B geographic distribution around the world absolutely mirrors that of the incidence of hepatocellular carcinoma. The virus causes the cancer. It is the most carcinogenic virus known to man, essentially. So you could think of the hepatitis B vaccine, it's an anti-cancer cure, or it's an anti-cancer preventer, essentially, because of the link is just so powerful. So that's to prevent hepatitis-related cancer is a good reason to treat the virus. And also, as I touched on before, if your patient may have very mild or inactive hepatitis B, but if they need to undergo immunosuppressive therapy for another medical condition, then that would be a time to consider treatment so that they don't become unwell from their Hep B whilst you're giving them treatment for something else. This is, again, the slide that Dr. Moyes had, and we'll just go over it again. The ALT reflects active inflammation in the liver, and in young people, it can be very quiet, there can be no inflammation, and yet the virus is actually running very, very high, and they are in an e-antigen positive phase. They don't really need treatment. The second stage is where the body's immune system is starting to really combat the virus, and the liver is really caught out in the middle. It's caught out in the crossfire. And you'll see the ALT will be fluctuating up and down, and the virus level will be fluctuating up and down. People who are teenagers or in their early 20s, we can sometimes see ALTs into the 800, 1,000, and then we check it, we keep an eye on it, and it settles down, and then we find 6 months later their virus status has changed from e-antigen positive to e-antigen negative, and they've gone from the very active form into the quiet form. So they then go into the stage here. So in terms of our monitoring, when we were doing our monitoring blood tests, we will sit with elevated ALTs for a couple of years and just see if the body's just going to do its business and the person's going to flick into the quiet form. So you don't have to treat just because you see 2 ALT blood tests of 80. We'll quite happily sit and watch that for a couple of years to see whether the person will go into the quieter form of the condition and not need long-term medical tablets, medical treatment. And then typically many adults are probably in this phase here where they have low levels of the virus and their ALT is running fairly normal. They don't need treatment, they just need monitoring. But the ones that we really want to pick up is where the virus starts becoming more active again in the middle age to older age. The virus is fluctuating, the ALT is fluctuating. They are the ones who are at risk of progressive fibrosis and damage. So specifically then, who do we need to treat? There's no point giving someone an antivirus tablet if they don't have detectable virus. So if someone has, you could have a raging ALT of a couple of hundred, but if their viral count is very low, they don't need treatment, go look for another cause. So starting point, a virus that's at least above 2,000. And obviously the higher it is, the more likely I want to treat. You need to then have at least one of the other 2 indicators, ongoing active inflammation or evidence of damage in the liver, probably from prior active inflammation. So one of those 2 things together, plus a virus that's up, that would be the time to consider treatment. Treatment, I would also have a lower threshold to treat if there is a particular risk of liver cancer, and I can speak to some of that in a later slide. Up until June of last year, Pharmac held quite tight purse strings on the criteria for commencing antiviral treatment for hepatitis B, and that was purely a cost decision because of the cost of the drug that they were bringing in. They capped treatment to people who really needed it clinically, and they had particular threshold. The prescribing had to be, the initiation of antiviral therapy had to be done by a specialist, hospital-based essentially, as well as infectious diseases physicians. That tight restrictions on prescribing from Pharmac has been entirely removed. Any prescriber in New Zealand can now commence a person on hepatitis B. And the reason for that is they've changed their supply and they've gone to a cheaper generic supply. I've got no issue or problems with the quality of the drugs that New Zealand Pharmac are now obtaining. I know in other things that hit the media, people talk about, the epilepsy drugs have been changed, the antidepressant drugs have been changed to a generic. I don't think it's been as good. People sometimes say the same for thyroxine, omeprazole, Losec. From my perspective as a liver disease specialist, I'm not aware of any issue with the quality of the generic antivirals. And yeah, no longer need special authorities. So who does not need treatment? And this is that the majority of adults that we just need to keep on monitoring are the people who have low virus levels, persistently normal liver blood tests, and no evidence of any fibrosis in the liver. They still need monitoring though. Their risk of liver cancer is much lower than someone who has hepatitis B that's really, really active, but it's still higher than the general population, so they still need to have an eye kept on them. And as I showed in that natural history slide, the disease activity can change over time, and we're only going to capture that if we're getting another look at that person's bloods periodically over time. So what are the antiviral treatments? So the two main ones available now in the current era are entecavir and tenofovir, and these are very, very effective antivirals. They've both been available in the international market since mid-2000s, and around the world there would be absolutely millions of people on these tablets. They are taken once a day, long term, and this is a patient education issue that we need to impress upon our clients all the time. They get given a 3-month prescription and they take it for 3 months and then they stop, and they're not aware that this needs to be taken long term. So when I say these tablets are effective, they really are. You take them and within a couple of months you will see the virus count dropping. It may not go completely to zero or not detectable, but you'll certainly get it under 100 or in most instances. But if you stop taking the tablet, the virus will, in most instances, will bounce back. So for most people, the treatment at this point in time does need to be long term. The clever people in all the big liver units and research labs are busy trying to work on finding a cure for hepatitis B, but it is not available now and is unlikely to be coming to market anytime in the next 5 to 10 years. But maybe in 10 to 15 years' time, it might be a completely different story and we may be able to cure. But at the moment, all we can do is very effectively suppress the virus, which absolutely has been shown to reduce the risks of progressive liver disease, liver damage, liver failure, transplant requirement, and liver cancer and mortality. So very effective, just got to take them long term. There are a few select situations where someone may be able to come off their antiviral therapy, but this really should only be done in conjunction with secondary care specialists. In terms of the risks of liver cancer, so hepatitis B is itself a major risk, and then in particular, who else beyond that is at extra risk? Older age, same with all cancers, they occur more in older people. If there is ongoing active hepatitis over a long period of time, so if we've got evidence that their ALT has been running 80 to 100 for years and years and years, and they've got a virus count that's in the 20s of thousands or hundreds of thousands, then I would be very concerned that this person's at high risk of liver cancer. The E antigen status, if they're positive, it carries a higher long-term risk as well. In terms of the family risk of hepatocellular carcinoma, there is a genetic component. We don't know the specific genetic blood test, but we know that there's family groupings. So for example, in the Whānau groups that are monitored very closely with the Foundation from the Eastern Bay of Plenty, who we've known for many, many years, we absolutely know the such and such Whānau, they've had, 5 of their family have had liver cancer. We've got the other family group, they've had about 5 or 6 members of their extended Whānau have been affected by liver cancer. So anytime there is one person with hepatitis B related liver cancer, we really want to know whether any of their family members also have hepatitis B, because they are at significantly increased risk and would warrant extra monitoring. The other liver-related risk factors, specifically here would be obesity and type 2 diabetes, would be a very significant additive risk for HCC. So the REACH-B score is something that Chris alluded to before. It's on your MedCalc apps. it's a rough way of estimating risk. So if I'm referring someone to secondary care, or if I'm writing a letter back to someone's GP recommending treatment, I might put the REACH-B score in there and say, look, the REACH-B calculator, which takes into account age, ALT, e-antigen status, gender and viral load, if that spits out a high risk predictor, I will say, look, that really needs to be taken into account when considering treatment, and potentially also we need to commence surveillance. I haven't got a lot else in here about hepatocellular carcinoma, but it's something, if there's any questions, I can talk more about it at the end. So in terms of the monitoring, I guess this is where the foundation comes into its own. So we're a charitable trust funded by the Ministry of Health to provide a monitoring program. We want to work with primary care. We know primary care have a vast amount of things on their plate to juggle, and we want to work with primary care to assist with the monitoring of this specific condition. So what we do is, for all the patients enrolled in our service, we send them out 6 monthly blood forms, and that includes the LFTs, the AFP, and that's one I haven't mentioned before, it's the alpha fetoprotein, which is a liver cancer blood test. It's effectively, it's a tumour marker, and also the surface antigen and some of the other serology blood tests, just to confirm that they have ongoing active hepatitis. And we do that 6 monthly. From age 40, we add in a couple of additional tests. The full blood count we do once a year, and the reason we do a full blood count is quite specific to the liver. And this is a whole nother talk in itself, but I'll just throw this in here. When a person has developed cirrhosis of their liver, one of the ways we can see that the cirrhosis is progressing and they're getting more damage is when their platelets start falling. And you'd be like, well, why? What's the link between the liver and the platelets? But it relates to the plumbing in the abdomen, and as the scar tissue increases, the spleen gets enlarged because of the back pressures, and they get a fall in their platelets. So we want to be watching for someone who's got Hep B and their platelets are falling. That would prompt us to go, we need to do an ultrasound to see whether they've got established cirrhosis. So that's why we do the full blood count. And also from age 40, we are now, even if that person has had normal liver blood tests, we are doing viral loads one-off, and then depending on how high it is, we might repeat it again in a year or two, just to take that into account in terms of that treatment decision. So what are we looking at when those bloods come back to us? So we have about 15,000 people-ish on regular monitoring with the foundation. So there's a lot of blood results coming back in. And the first, we are going to be automating some of these processes. Essentially, if the bloods come back in and they're all entirely normal, then the process will be just that they get tick box, they'll get a result saying your bloods are normal, and we send them out another one in 6 months' time. And we're in the process of automating that. But at any time the blood tests are abnormal, comes in front of a human, and then we look at it, we look at the pattern, how high are they, have they been up before, and we have processes and protocols at the foundation to look at that and assess what needs doing. And depending on how high or how abnormal the liver blood tests are, there's a number of actions that we can do within our system, whether we just, it's not that elevated, simple, no issue, just repeat it in 6 months' time, or whether we actually need one of our nurses, who you've all seen today, they might call the client just to get a clinical correlation. Are you unwell at the moment? Did you get the bloods done because you've just seen your GP because you've had fevers? Sometimes the bloods actually come to us as a copy to us from the GP, and they weren't ones that we'd sent out. Or are they feeling fine, but actually they've got an ALT of 300, and that can actually happen. You can have flares of hepatitis with your ALT into the hundreds and not actually feel any different. So this is why someone saying, well, I feel fine, I don't think my hepatitis B is causing a problem, that just doesn't wash. You can only say that by monitoring of the blood tests, because you may not feel any different with an ALT of 300 than what you would if the ALT was normal. So our nurses might call the client, and depending on how high and how abnormal, then the scenario can be escalated to myself or Chris Moyes, and we'll look at it. And then the actions that we can do, maybe just arranging for a repeat sooner than 6 months, or if things are particularly high, we may send them a further blood form to check a few other parameters, liaise with primary care, or refer to secondary care for further assessment or treatment. So a number of different actions, all very individual to that patient. So I'm going to go into some cases now, and then we'll have time for questions. So this is Mr. RH, a 47-year-old Māori gentleman. We do know a little bit about him. He does drink some alcohol, and he's not known to have any family history of liver cancer. We don't know other things though, such as his BMI or comorbidities. From the blood tests in our system, we know that he's E antigen positive, and his viral load is very high at 21 million or 8 log. So that's extremely high. On the blood tests that we have available to us, we can see that his ALT is chronically elevated, 40 to 90, and his GGT is also elevated. He's never had a FibroScan or an ultrasound, and his platelets are normal. So the impression from that, he has chronic, active, E antigen positive hepatitis from what I've just shown you, and he is at significant risk of liver-related complications. That is a clear-cut treat. There's no ambiguity about that at all. He needs treatment, and actually, depending on various thresholds, you need to consider doing ultrasound surveillance for liver cancer. So then the only issue is how can we make that patient-centric? So that's the medical recommendation, treat. And then we need to put the patient into the centre and go, well, who, where and how, who's doing this? Where do they live? What's their transport options? Have they got a record of prior non-attendance at secondary care appointments? Do they have shift work? Do they have work that they can't get, easily get hospital appointments? All of those things need to be taken into account. Previously, we had to refer to secondary care to get them treated, whereas nowadays, if I've got someone who's potentially got some barriers to access of care, if all of these things were present, I would be phoning the GP or writing it to the GP saying, look, your person who lives in the back blocks of so-and-so can't get up to Hamilton Hospital for an appointment. Can you please start them on treatment? This is a clear-cut indication. Please bring them in. Please start them on treatment. And so that's where I'm going to be, potentially leaning on GPs and nurse prescribers more, is to take up that role of actually, you know what, there's no ambiguity here. You need treatment. High risk of progressive problems. This can be done in primary care. So that's how we want to be able to work with you guys. So another patient, 55-year-old Chinese lady. We know that she has some metabolic issues. She's obese, she's on diabetes and blood pressure medications, but she drinks very minimal alcohol. We're not aware of any family history of hepatocellular carcinoma. From the virus perspective, she's E antigen negative, and her virus count is very low. It's 800. And remembering that framework, 0 up to a few million, 800's low, really low. So that could also be written as 2 log on your blood test results. From the perspective of her liver blood tests, her ALT is ranging between 30 and 60 over time, and her GGT is 80 to 160. So both of them are up 1 to 3 times the upper limit of normal over the long term. So my impression for this lady would be that she has inactive chronic hepatitis B. So that she's got hepatitis B, but it's not active. Her deranged liver blood tests are likely to be secondary to fatty liver disease, given that she has features of the metabolic syndrome, which I'm going to speak to quite a bit more tomorrow morning. So our plan for her, we're just going to continue to send her routine blood test forms from the foundation, but we're not going to do any treatment for that ALT of 30 to 60, but we may at some point write a letter to the GP saying your patient has chronically elevated liver enzymes. It's not due to the hepatitis B virus. Please consider other causes when you assess your patient. The third patient. So this is a 50-year-old gentleman. We don't know much about him, and we don't know his BMI. From the virus perspective, it's E antigen negative, with the viral loads low-ish, not particularly high, but it's in the realm we would start looking at it. And the liver enzymes are mildly elevated. And these are over time, not just one-off tests. So for this gentleman, he's got chronic hepatitis B, E antigen negative, some evidence of active hepatitis, but not much. And the viral load's not particularly high. So this is the grey zone. This is the area where it's like, well, do we treat, do we not? Really, we need more information. So this is the situation where I'd probably be referring them to secondary care. So no disrespect to primary care clinicians, but this is where it needs a little bit more nuanced conversation with the patient and further assessments. I think these are the ones that should be seen in secondary care, because you're making a decision about starting them on a long-term antiviral medicine. So we get further information. He does have significant comorbidities that affect the liver, including obesity and diabetes. He has a FibroScan that gives a result of 9. And so FibroScan, we haven't got much on this in our talks at the moment, so I will just spend a minute or two on this. It's a non-invasive procedure where we use ultrasound type technology to hold a probe over their liver, and we take a number of readings, and it gives us an estimate of whether there's any fibrosis or scarring present in the liver. And then the range of numbers that we get can be anything from sort of 3 up to 75. If you're less than 7 or 8, effectively you've got, mild or no fibrosis. Certainly less than 7, your liver is normal. The clear cutoff though is if your FibroScan score is above 11, that we would say is effectively diagnostic of cirrhosis, with the caveats and the limitations of the test. No test is perfect, but broadly speaking, if you've got a number above 11, 12, then you have cirrhosis. The higher that number it is, does correlate with more progressive disease. So this gentleman had a FibroScan score of 9, and so I would add that into the mix and say, well, actually, he's got, the virus is only, it's only 8,000, the ALT wasn't that high, but he's got significant comorbidities that will affect his future liver and overall health outcomes, and he has a decent amount of damage in his liver. I would recommend that someone like that go on antiviral therapy in a patient-centred conversation if they wanted to do that. So that has been a vast amount of information, but I guess the points I'd like you to take home is that to assess a person with hepatitis B, you need to take into account patient factors, virus factors, and liver factors, put all that into the mix, and then try and come up with whether the person needs treatment. I think there's clear-cut need for people to be on treatment if they have evidence of high virus levels with ongoing liver inflammation. The medicines that we have available in New Zealand are very effective and very safe, and treatment is usually long-term. For the majority of the rest of people though, we do recommend long-term monitoring and always seek advice before stopping therapy.